Hello everybody, I'm Tim Weber and I will be holding this webcast today about the functional outcome analysis of navigated minimally invasive total hip endoprosthesis using musculoskeletal modeling. As you can see, the email address if you want to contact me, this will be repeated in the end of the webcast. First of all, I want to give you an outline of what we will be discussing today. So the first part is a prospective study, which is about the clinical gait analysis combined with musculoskeletal modeling in clinical practice. We were researching into the biomechanical and clinical outcomes of patients after computer-assisted minimally invasive THA using clinical outcome scores combined with gait analysis and musculoskeletal modeling. The second part is a retrospective study, which will be discussed later on. So, first, I give you an overview about the patient collective that we examined in this study. Here you can see three diagrams. On the upper left side, you can see the distribution of age and the patients. On the upper right-hand side, you can see the distribution of patients in terms of body mass index. And on the lower left-hand side, you can see the distribution of the months post-OP when the gait analysis was actually conducted. So, the mean age was 62.9 years, the mean BMI was 27.56 years, and the mean time post-OP is 21.4 months. The post-OP time means the time when the gait analysis was conducted after the operation. So, when we move on to the methods of the prospective study, we actually measured three angles using a standard goniometer. As you can see on the lower left side, there's the flexion angle displayed and how it was measured. In the middle, there's the abduction angle displayed and how that was measured. And on the lower right-hand side, you can see the external rotation angle and how it was measured. Measurements were validated by repeating them 10 times in every leg and for every angle. We also used to evaluate the subjective being of the patients, we use clinical hip scores which have been validated before. For example, the Mayo Dobin score, the Harris hip score. Of more interest are the Western Ontario and McMaster Osteoarthritis Index, which will be now shortened as WOMAC score, and the Hip Disability and Osteoarthritis Outcome score, which is the whole score. These two scores actually contain sub-scores, like all of the scores do, of biomechanical interest, such as stiffness and function in daily living. Gait analysis was conducted in the gait laboratory of the University Clinic in Regensburg, according to Perry et al. If it comes to gait phases. Here you can see a skeleton and from front and rear view and the marker set and how we applied the marker on each patient. You can see here the front view and you can see the rear view. In this picture you can actually see a fully prepared patient right before the gait analysis. And as you can see, we used an EMG biovision system to measure different EMG muscles such as the gluteus maximus, the rectus femoris, the tibialis anterior, and the gastrocnemius lateralis. In these three pictures, you can see a patient during gait analysis. The first picture is the heel strike of the right foot. Second picture actually shows the heel strike of the left foot, and the third picture shows the heel of the left foot. Yes, this is actually the gait lab of Regensburg. Here you can see EMG measurements of all four muscles on every leg, on the operated and the not operated side, divided by heel strike and heel off. Well, we used musculoskeletal modeling to examine the hip reaction forces. We used the musculoskeletal modeling system, the antibody modeling system, the AMS, and we use the Antibody Managed Model Repository version 1.2 to get lower extremity model. As input, we use the marker trajectories and the ground reaction forces of the gait analysis, and as outcome, we would get the hip reaction forces, the hip variation angles, and the muscle activity. Down here on this picture, you can actually see the same patient as we have seen before, with the heel strike of the right foot, the heel off of the right foot, and the heel strike of the left foot. Here, in this small little diagram, you can see the muscle activity in red divided in heel strike to off strike and off of the right and left leg. So we want to determine if the gait is natural or not, but the question is, how do we examine if the gait is natural? Well, up to now, geometric parameters have been observed by CC et al. That they actually use the symmetry to see if the gait is natural or not. So the symmetric gait pattern was assumed as the golden standard. We actually did quite the same thing. We calculated the symmetry due to the formula that you can see here, the RI ratio, which is always the treated side versus the not treated side. This can describe forces and angles. Okay, so we move on to the results of the range of motion. In this chart, you can actually see the results for the abduction angles of the operated side, represented by circles, and you can see the abduction angles of the not operated side represented by squares. In this diagram, you can see on the x-axis subject number and on the y-axis the actual range of motion angle. The black line represents the mean value overall participants. Of more interest are the two charts on the bottom, where you can see on the x-axis here the months possibly when the gait analysis was conducted, and on the y-axis you can see the abduction angle on the lower left side of the operated side and on the lower right-hand side of the not operated side. We combined the range of motion with scores, subscores. Okay. So, what have we seen right before? Well, the flexion angle actually increases on both sides, on the operated and on the not operated side, as well as the abduction angle does. Rotation angle decreases on the operated side versus one's possibility and stays like it is on the not operating side. Well, please notice that the study underlies a very strong scheduling in terms of the study protocol. We have few participants to prove good statistical evidence because this is a feasibility study. We wanted to know if this was possible and if it's meaningful what we wanted to do. So there is no good proof, no good statistical proof because it was a feasibility study. Here we can see the results in terms of hip scores. On the left side, there's the whole score in total represented. On the x-axis, we would have the subject number. On the y-axis, we would have the whole score total in percent, and the black line represents the mean value overall participants. On the right chart, we also have on the x-axis the subject number, and on the y-axis again the hip score in percent, which is now the whole score. Please notice that comparing these total scores is not. Please notice that the total scores can't be compared, but the subscores of the patients actually can. Both scores contain subscores of biomechanical interest, such as stiffness and function in daily living. Here we can see the results that have been examined by the antibody modeling system. First of all, we have the hip reaction forces with a minimum of 0.9 times body weight on the mediolateral force that appeared in subject 6 on the not operated side. We have a maximum of 6 times body weight in the proximal distal hip reaction force, which appeared in subject 12 on the operated leg. Second of all, we have seen the hip variation angles with a minimum of 2 degrees on the flexion axis. It appeared in subject 11 on the operated leg, and a maximum of 50 degrees on the rotation axis, which appeared actually in subject 12 of the operated leg. Here we can see 4 different charts which are representing all the results of musculoskeletal modeling. I want to give you a quick overview. I don't want to get too much into detail. On the x-axis, we can see on all diagrams subject number, and on the upper diagrams actually represent the hip reaction forces, and on the bottom we can see the hip variation angles. The y-axis of the upper diagrams represents the hip reaction forces in times body weight, and on the lower side, on the downside, you can see on the y-axis the hip variation angle of every subject. The triangle represents the mediolateral hip reaction force in the upper diagrams. The circle represents the maximum of the proximal hip reaction force in body weight of the operated leg on this diagram, and of the not operated leg in this diagram, where the square actually represents the anterior-posterior hip reaction force. Down here we can see the hip variation angles, which are represented by circles, squares, and triangles as well. The circle represents the hip variation angle in the flexion axis. The square represents the hip variation angle in the abduction axis, and the triangle represents the hip variation angle in the rotation axis, here in the operated leg and in the not operated leg. I'll always wait for a couple of seconds until you can see the next slide. So let's move on to the results in terms of ratio. We examined 2 different ratios as a measure for symmetry. First of all, the ratio R of the hip reaction forces, where we found the minimum to be 0.4 in the medial lateral hip reaction force, and a maximum of 2.1 in the proximal distal hip reaction force. The widest range of ratio appeared in subject 9 with 1.1 to 2.1, and the smallest range of ratios in terms of hip reaction forces appeared in subject 16 from 0.4 to 0.5. Second of all, we have the ratio of hip variation angles, where we found the minimum to be 0.25 in the abduction axis and a maximum of 1.75 also in the abduction axis. The widest range we found to be from 1.5 to 1.75, which appeared in subject 8. The smallest range appears in subject 4 with 0.45 to 0.9. So, as I mentioned before, we had a look into the subscores of biomechanical interest. So what do we have here? On the x-axis, you can see in all 3 diagrams, actually the Womack subscore stiffness in percent. On the y-axis, you can see the ratio of the hip reaction forces. In the first diagram, you can see the ratio of the mediolateral hip reaction force. On the second diagram, you can see the ratio of the proximal distal hip reaction force. And on the third diagram, you can see the ratio of the anterior-posterior hip reaction force. As you can see, there's from 80 to 100%, so the ratio of the hip reaction force appears to be more likely above 1. This appears in the proximal distal force and in the anterior-posterior force. We actually combined all ratios of hip reaction forces and hip variation angles with the subscores of biomechanical interest. So, what do we see here? If we combine the subscore for stiffness versus the ratio of the hip reaction forces, we can see an increase of with an increase of subscore. Actually, the ratio of the hip reaction forces also increases. It's more likely above 1. This appears in the anterior, posterior, and the proximal distal hip reaction force. If we combine the functional daily living subscore with the ratio of the hip variation angle, we can see with an increase of subscore, actually the ratio of hip variation angles decreases. This has disappeared in the flexion and rotation angle. So what does this all tell us? It says that the subjective flexibility increases while the objective measurement stands opposed to that. But please notice, because of the scattering of the patient collected, no reliable evidence can be given, but the results indicate a certain pattern. Therefore, no quantitative scientific questions can be answered, but we sure can answer some qualitative questions. Therefore, we analyze 3 subjects, which will be discussed now. On this slide, we can see the results of the antibody modeling system in these diagrams in terms of hip reaction forces and hip variation angles, and we can see the results of the measured EMG values and the calculated muscle activity. In this diagram up here, you can see on the left-hand side all values for the operated leg, and on the right-hand side the values for the non-operated leg. In this chart, the ground reaction forces of the operated leg are shown, as on the right-hand side, the ground reaction forces of the non-operated leg are shown. Here we can see the green line represents the proximal distal hip reaction force, the blue line represents the anterior posterior hip reaction force, and the red line represents the mediolateral hip reaction force. Down here we have the hip variation angle in degree, where the blue line represents the flexion angle, the red line represents the abduction angle, and the green line actually represents the rotation angle. Subject 4's body weight was 60 kg. The gait analysis was carried out 5 months post-surgery. The patient was 55 years old with a BMI of 23.15. So why did we pick subject 4? It actually has the lowest moment and whole score. So, as we can see here in the ground reaction forces, they indicate a typical gait pattern with heel side and heel off. So, again, we picked subject 4 to analyze because it had the lowest hip scores, it stayed below 60%. The maximum proximal distal hip reaction force is actually 5 times body weight on the non-operated side, and the ratio of hip reaction forces in the proximal distal direction is 0.6y. So, why does there appear such a big hip reaction force? So, if we look deeper into the subject 4's subscores, for example, the quality of life subscores and the personal satisfaction subscores, we can see that subject 4 is in pain. Because of the musculoskeletal modeling results, we can say that this is due to biomechanical reasons. Subscores also show a remarkable loss of confidence in the operated leg, which, as I mentioned before, are shown by the subscores, the quality of life subscore, and the personal satisfaction subscore. The patient actually takes an overcharge of the non-operated leg into account to aid the recovery of the operated leg. Let's move on to the next subject. Here the results of subject 9 are displayed. Subject 9's body weight was 78 kgs. The gait analysis was carried out 26 months post-operatively. He was 60 years old, had a BMI of 26.03. We picked this subject because the widest range of the ratio of hip reaction forces appeared in this subject. As mentioned before, there we have the ground reaction forces, which kind of indicate a natural gait pattern, but is not as clear as before. Still, the gait pattern can be normal. Here we have the green line represents again the proximal distal hip reaction force on the operated leg and on the non-operated leg. And as we can see, we have a very high hip reaction force in the proximal distal direction. Down here we have again compared the EMG measured values represented by the blue line and the calculated values from the antibody modeling system represented by the red line. Subject 9 actually matches literature data in terms of the EMG measures, the best of all subjects. But please notice that EMG measurements are placed with electrodes on the patient can produce random results like Morrissey at a conference with results presented. So we have a maximum. So we have a maximum hip reaction force of 5.66 times body weight in the operated leg, and we had the widest range of the ratios of hip reaction forces. What does that tell us? The widest range of the ratio of the hip reaction forces? It tells us that in subject 9 appears the biggest difference between the operated and the not operated side. According to Perry et al., the indicator for a disturbed gait pattern would be a reduced flexion in the operated leg, which shows a loss of muscle control, which we actually found to be in subject 9. An increased abduction, however, would indicate a muscle weakness. We didn't find the abduction to be increased, actually. The indicator for natural gait pattern is actually the compared muscle activity, the EMG measured to literature data. So, the patient appears to have a natural gait pattern, but still has very high hip reaction forces. Why can that be? Actually, the patient is able to provide full muscle force, but is not able to control it. So he overcharges the hip joint, which will result in a lower durability of the implant. Here the results of subject 15 are displayed. Again, you can see the red line which represents the ground reaction forces on the operated leg and on the not operated leg. Here we can see the hip reaction forces on the operated leg and the not operated leg and the hip variation angles of the operated leg and the not operated leg. Subject 15 weighs 80 kgs. The gait analysis carried out 11 months post-op. It was 68 years old, had a BMI of 30.5, and it also had very low hip scores, similar hip scores to subject 4 actually. Down here we can see again the compared values of the measured EMG values and the calculated muscle activity represented by the red line. So, the ground reaction forces of subject 15 actually indicate a normal gait pattern. The maximum hip reaction forces, the maximum proximal distal hip reaction forces, are 2 times body weight. If we have a look into the symmetry or the ratio of the operated versus the not operated side, it appears to be very similar. So why does the patient have so low hip scores? If we have a look into the subscores, the quality of life subscores, for example, or the personal satisfaction subscores, we can see that the patient is in pain. But the objective analysis shows us this is not due to biomechanical reasons. Okay, so move on to the conclusions. The quantitative analysis is challenging due to the high scattering of patient collected and the number of participants. But please notice this is a feasibility study, so we actually used nearly every patient we could get. But a certain pattern can be found in combining subjective outcome scores with objective measurements actually. This actually points out to the combination of the ratios with the subscores, the Womack subscores, and the whole subscores. The qualitative analysis of objective measurements combined with subjective questionnaires gives deep insight into the functional outcome of THR and leads to a better understanding of all the mechanisms. We've seen before, subject 4 and subject 15 had very similar hip scores, but actually had but the reasons, because it was very low subscores, were different. Subject 4 due to biomechanical reasons, subject 15 due to other reasons, psychological or whatever. So we move on to part 2, which is the retrospective study. That was the evaluation. What we tried to do was evaluate medical imaging using musculoskeletal modeling. It draws its focus on the influence of image accuracy on the hip biomechanics in order to validate if X-ray images can be used for proper operational planning or not. We used two different types of imaging techniques. First, we used standard clinical analog X-ray images. They were digitized using the X-ray scanner and optimized in terms of sharpness and color depth. You can see an example of a very nice picture here. Second, we used CT scans, transversal CT scans actually. We segmented these CT scans, as you can see down here, using ITT-STEP 2.0, which is an open source software, and it's actually a very nice tutorial. If you just Google it, it's very good. That's very nice. And we achieved 3D models from the transversal CT scans. So what else did we do? We observed several parameters of interest. First, the pelvis width, which is defined as the distance between hip joints. We observed the CCD angle on both sides, the operated and the not operated side, and the local offset on the operated and the not operated side. These parameters of interest were measured in both X-ray and CT images. We then conducted musculoskeletal modeling using the antibody modeling system. As the activity of daily living, we picked an event which lasts for 10 seconds. The analysis was conducted for 10 seconds. As an input, we would have the measured parameters of interest of the X-ray images and of the CT images. As an outcome, we would have the hip reaction forces and the muscle activity. In this picture, you can actually see an event of one patient at 0 seconds. Here we you can see the event at 5 seconds, and here we see an event at 10 seconds. The muscle activity over time is displayed in this diagram on the lower left side. So, what did we get out of this analysis? Here you can see the hip reaction forces from the maximum CCD model. We actually had a patient collective of total 16 patients, analyzed all CCD angles in the CT images, and picked the maximum values. On the left-hand side, you can see the hip reaction forces of the CT models, of the operated side, and of the not operated side, and of the operated side. On the right-hand side, you can see the hip reaction forces of the X-ray models, again on the not operated side and the operated side. The blue bars represent the hip reaction forces at the point of time 0 seconds. The green bar represents the point of time 2.5 seconds. The red bar represents the point of time of 5 seconds, and the magenta line bar actually shows the hip reaction force at 7.5 seconds. The hip reaction forces appeared to match the literature data actually. Group 1 in all 4 diagrams, you can see here, we have the hip reaction forces of the medial-lateral direction. We have the hip reaction forces in group 2 of the proximal-distal. The proximal-distal hip reaction forces are represented by group 2, and group 3 represents the hip reaction forces of the anterior-posterior in the anterior-posterior direction. But what are these black lines actually doing? So what we did was, we used the CT scans and 3D models as gold standard. We subtracted the measures of the matching patients of the parameters of interest, such as local offset or pelvis width, and then we modeled for the CT and the X-ray measures there. Then we modeled the X-ray and CT patients actually. What we then did, we subtracted the hip reaction forces, the X-ray hip reaction forces from the CT hip reaction forces. So this black line actually shows the maximum hip reaction forces in proximal distal of the X-ray, and this black line represents the maximum hip reaction forces of the CT model, just to give you a feeling of how the difference, where the difference is, and how big the difference can be. It's the same for all diagrams. So, what did we find? The inaccuracy of geometric measures for operational planning highly influences the biomechanics of the hip up to 0.9 times body weight. So, what does this actually tell us? Every measure, as we all know, every measure underlies a standard deviation, and in this field of this standard deviation, if we look into it, it can make the difference from up to 0.9 times body weight. So this leads to the conclusion that operational planning using radiographs is challenging. Blumentritt et al. Tried to develop a model for operational planning, a biomechanical model of the hip for operational planning, but he actually they used 10 landmarks which also underlie a very high scattering that was presented in the Chaos conference this year. And as we showed, the problem is, or the challenge is, that this scattering of the standard deviation can lead to a difference of up to 0.9 body weight, which is, well, yeah, not so good. But please notice, we also have here a little patient collective because there was a feasibility study, and we only had one examiner examine all the pictures and all the 3D models. And the accuracy can be improved using digital X-ray imaging. So here's room for more. So please feel free to ask any questions. If you want to contact me, there's my email address